Now, I would like to discuss with you the topic of upstream and downstream factors that influence health disparities in the United States and here in Brooklyn. So, what are upstream and downstream? Okay, this is a wonderful video of the upstream and downstream parable explained. Focusing on those upstream factors, and this is being brought by Alexis Kuskan.
Hi, everybody. So, welcome back to Social Determinants of Health. Before we get started, I want you to take a look at this picture and think about what you see here. You've got a river where you've got kind of the upstream part of the river. You've got downstream part of the river, right? So, upstream is a little bit closer to where the mouth of the river would be, right? And downstream is, again, downstream. And I want to read a little story to you that is from a book called Prevention as Primary Strategies for Community Well-Being. So here's that little vignette. While walking along the banks of a river, a passerby notices that someone in the water is drowning, and they help pull a person to shore. After pulling the person to shore, the rescuer notices that there's another person in the river in need of help. Before long, this person notices that the river is filled with drowning people, and more rescuers are required to assist that initial rescuer. Unfortunately, some people just can't be saved, and other victims fall back into the river even after they've been saved and pulled out of the water. At this time, one of the rescuers starts walking upstream. "Where are you going?" another rescuer asks. The upstream rescuer replies, "I'm going upstream to see why so many people keep falling into the river in the first place." As it turns out, there was a bridge that led across the water upstream, and that bridge collapsed, and people were falling into the water, into the river. The upstream rescuer realizes that fixing the bridge will prevent other people from ever falling into that river again in the very first place. So, there is a quote that's by an American feminist, journalist, and social political activist, Gloria Steinem. And she said, "We're standing on the bank of the river rescuing people who are drowning, but we have not gone to the head of the river to keep them from falling in. And that's our task in the 21st century." She wants us to, with this remark, she's using this analogy to basically say that we need primary prevention. We need to stop people from falling into that river in the first place by ensuring conditions so they won't fall into that river and put themselves in danger in the first place. More often than not, as public health practitioners, as health professionals in general, we focus on saving people downstream. We find people when they have high blood pressure and are at risk from complications from type 2 diabetes. And we really focus on providing medical treatment instead of trying to really focus on helping people to prevent conditions that throw them in the river in the first place. And this analogy, this story, this quote by Gloria Steinem is all about saying we need to go to the root of the problem. We need to go upstream and look at what's happening upstream. What conditions are causing people to fall into the river in the first place? And so instead of treating individuals one by one for adverse health events such as disability and illness that's caused by the complications of disease, we really need to start focusing on what can we do to really fix that hole in the bridge. What can we do to focus on factors that later on cause disease and disability? And those would be such upstream factors as the social determinants of health, such as socioeconomic factors, as working on the social environment of an individual, or even changing the built environment around people to make it easier for them to live healthier lives. How do we do that? Well, we target social determinants of health by changing policy, by making changes in the physical environment, by making changes in the built environment. And so therefore, really focusing on changing the context around an individual to make it easier for them to live a healthier life over the course of their lifespan instead of waiting until it's too late. So that's what's meant by upstream and downstream factors. And as health professionals interested in the social determinants of health, we want to know what is upstream and what can we do to change upstream factors to help prevent and control adverse events that happen downstream.
I love that video. It's concisely summarizes the story, and it also provides, in a way that I think is really clear, the differences. The one thing that she didn't talk about was that midstream. So we understand that upstream are those structural inequalities, those things in the built environment that are preventing people from being able to take care of themselves or putting them at harm, etc. Downstream is basically what we see here at Downstate. Downstream are the consequences of these health inequalities in terms of increased burden of disease, people showing up for late diagnoses, et cetera, and treating, of course, like chronic illnesses, conditions that could have been prevented in that midstream level, which is all about prevention. It's about addressing early around lifestyle change, around diet, exercise, sleep, etc. And so it's really important for us to understand why we see such a plethora of health disparities here. It's because this is where the burden of that downstream trickle comes. So upstream and downstream factors refer to the different levels at which social and environment determinants influence health outcomes. Upstream factors are the root causes of health inequalities and are often related to social structures, systems like poverty, discrimination, lack of access to education and healthcare. Downstream factors are those immediate consequences of the upstream issues, such as, I actually think these is like more of the midstream factors in terms of higher burden of smoking or poor diet, chronic disease, but absolutely chronic disease and mortality or multimorbidity and mortality are absolutely downstream factors. Upstream is, to address social determinants of health, condition in which people are born, grow, live, and work. This is the definition, actually, of social determinants of health, are those non-medical factors that impact people in terms of across the life course, in terms of how we're born, how we are able to grow up, live, work, and be able to live our lives. The midstream factors, these are the modifiable or individual behavior factors that include helping individuals to understand the importance of physical activity, nutrition, smoking cessation, maternal health, just graduating from high school, as well as violence control. And the downstream, again, are these chronic disease, often in terms of overwhelming our emergency systems, et cetera. Again, social determinants are non-medical conditions. They include conditions that affect us in terms of where we're born, grow, work, and live and age. Individual factors in terms of upstream factors include class, race, ethnicity, immigration status, gender, sexual orientation. This is a chart that also breaks down in terms of, also provided by KFF, in terms of what is really driving health disparities, and that is these social economic inequalities, such as unemployment, low income, debt, medical bills, in terms of the physical environment, poor housing, lack of transportation, lack of parks and outdoor spaces, playgrounds, walkability, education, low literacy, early childhood education in terms of, I'm thinking in particular in terms of addressing learning disabilities early on, food insecurity, limited options to healthy food options. Social components include just having community engagement, having spaces and places for the community to be able to get resources. And of course, healthcare. Limited options within neighborhoods in terms of urgent care or hospitals. Unfortunately, here in Brooklyn, we've seen a lot of hospital closures, which is absolutely impacting and limiting individuals and communities across Brooklyn to have access to health care. So the thing that is really important to understand here is that the majority of these health disparities are created by these socioeconomic factors, about 40%, okay? 50% can be traced back to just the zip code that you live in. But it's also important to understand that right behind socioeconomic factors is that middle area, the midstream, where we can actually have an impact in terms of promoting preventative medicine, in terms of tobacco, smoking cessation, trying to help people understand in terms of the dangers of processed food and fast food, to talk about the dangers of alcohol use. It's really wonderful to hear that Gen Z is drinking less than its prior generations, and they're starting to understand that alcohol use of any kind is not beneficial. But the truth is only 20% really are directed by healthcare. But that's the space that we work in and we live in. And so this is the space that we also can think about our interventions. So in addressing upstream factors, we need policy, we need good governance, we need unfortunately, policy and governance right now is actually undermining or exacerbating, making it more difficult for individuals to access health care and these social welfare benefits. Cultural factors also can play a role, whether it's around beliefs, values, and norms around healthcare and beliefs in healthcare systems. In the very first video, they talked about medical mistrust, and medical mistrust in particular among Black and Indigenous individuals in terms of the legacy of Tuskegee and forced sterilization among Hispanic and Latino women. And then finally, we have the experience of racism and discrimination that is now, I feel, more prominent than ever. And the fact that a lot of people feel very emboldened to talk about or to express their racism and discrimination, and that there are, I believe that, and I really like within healthcare systems like ours, that there are mechanisms to address that. The thing is that we need to really make sure that we do more within our systems to make sure that we are helping our staff, our faculty, our students, the physicians and nurses and OTs and PTs and everyone who works in clinics to understand the impact of implicit bias and discrimination on the healthcare that they are providing. 5 facts about older adults and healthcare experience by race. So older Blacks report more unfair treatment in healthcare settings than other groups of older adults. And this is 3 particular questions that were asked in terms of, do you think that this discrimination is because of your race or your ethnic background, or based on some other factors such as gender or health insurance status, or and the percent that said yes to both of these. And we can see in terms of Blacks that this percent is higher across all 3 of these question categories. Half of Blacks age 65 and older say that they are preparing for insults or feeling diminished when they are in the clinic. And this is just absolutely awful, that people are walking into clinic expecting not to be treated with dignity and respect based on the color of their skin. The fact that people are prepared to experience bias from either their doctor or healthcare provider is highest among Blacks, that they feel that they have to be careful about their appearance of being treated fairly, highest among Blacks, and yes to both of these, both higher across the board for Black Americans, followed by Hispanics, and then Asians. Hispanic and Asian older adults report fewer positive healthcare experiences than their Black and white counterparts. And the majorities of older Black, Hispanic, and Asian adults say fewer than half of their healthcare visits are with a provider who shares their background. It's not always possible to have a perfect concordance in terms of provider and patient. However, there is growing evidence that this does have an impact on the ability for our patients to be able to open up and to be able to to build a rapport and trust with their providers. However, when there is a disconcordance, the onus is, of course, on our patients who, or if there's a mismatch, for our providers to do what they need to do to make sure that they are helping their patients understand that that incongruity between sort of racial and ethnic background is not going to play an impact in their health and the care that they receive. So some downstream factors. Individual behaviors, obviously. This is where we need to work on preventative medicine in terms of talking about we can never talk enough about the impact of smoking, unhealthy diets, lack of physical activity, sedentary. And this is in particular for older adults. Older adults actually have the highest, I believe the veteran generation has the highest level of smoking compared to other generations. And as we get older, we become more sedentary. We're no longer working. And so we need to focus in on these things that often happen after retirement, after people stop working, that exacerbates or undermines their health and well-being. Morbidity and mortality, chronic disease, injuries, and permanent death, premature deaths are often the result of these upstream factors. And this is what we see. This is the evidence in health disparities, this disproportionate burden of morbidity and mortality. And then also access to health care and the fact that so many individuals have delayed or limited access to care and are coming in when they're super sick and missing those opportunities for preventative screens to be able to identify and diagnose problems before they manifest into more serious disease. Compared to white, this is a slide talking about white Medicare beneficiaries and Black beneficiaries are less likely to be married and more likely to live alone. I wanted to include this slide because I think it's really important also to think about some of these social variables that have an impact on health and well-being and disparities. So having social support, which is a huge issue when we're talking about our aging population, absolutely is a buffer to making sure that you are getting what you need. I would always tell people, my grandfather, who was born in 1893, lived to be over 100 because of my grandmother and the fact that she was with him at every doctor visit. And so being married and having a partner has a huge health benefit for men in particular, but also to emphasize that for those who are not, that this can also be a risk. Living alone, as you can see here in terms of disparities with Blacks compared to white and Hispanics, Blacks have a lower level of percentage in terms of being married, higher percentage of living alone, lower percentage of living with a spouse, and in terms of living with children only, they are on the same level with Hispanics. Coverage, access, and the use of care among people of color compared to white people. This particular bar graph is showing in terms of the perceptions of it being worse, no difference, better. And here you can see in terms of coverage and access to care is worse for both Hispanic and First Nation, Native Americans, and Alaskan Natives, both 11 and 10% compared to 8% for Blacks, 4% for Asians, and for Pacific Islanders. And these are all in comparison to their white counterparts. This final video, I love this video. This video is highlighting that Black patients face healthcare and discrimination, in particular when trying to access treatment or resources for dementia and Alzheimer's. We are, of course, again, the Bridge program, and here our focus is on older adults. We happen to have enormous expertise on mentation in terms of Alzheimer's, dementia, and mental health malaise among older adults. And so I wanted to just emphasize also the disparity in access to treatment for dementia and Alzheimer's among Black patients.
Back, new research from the Alzheimer's Association shows that African Americans are discriminated against when it comes to getting care for Alzheimer's disease. Emily Cohen hears from a woman about how tough it was getting her mother diagnosed.
Despite several red flags, Karen D. Jones says it took years to get her mother diagnosed with Alzheimer's disease.
One day I got like this strange phone call at work, and she was just real incoherent. And it was kind of strange, and I got nervous, but then by the time I got to her house later on that day, everything was fine.
So Karen immediately called her mother's doctor, but she says he seemed to dismiss her.
The phone, when the doctor said it, like, I can't help you, like, really?
So her mother saw a geriatric doctor who also told Karen that nothing is wrong with her mother. But a year after that visit, the diagnosis came. Her mother had Alzheimer's disease. That's 4 years after Karen initially reached out to her mother's doctor.
Just getting that initial help and somebody to recognize and acknowledge that this is an issue or a concern, it was very disheartening.
The executive director of the Northwest Ohio Alzheimer's Association says there's no time to waste in getting a diagnosis, especially as we move toward the first ever treatments for Alzheimer's disease.
We need to have early diagnosis for people in the mild cognitive impairment stage or in the very earliest stages of actual dementia in order for those treatments to be effective.
The Northwest Ohio Alzheimer's Association says if you're having a hard time getting yourself or a loved one diagnosed, feel free to reach out to them for help. Reporting for WTOL 11.
Some downstream factors that impact health disparities that we can address in terms of living conditions. Here I'm thinking of unsafe housing, lack of environmental issues in terms of hazards, living around sort of environmental problems in terms of pollution, lack of access to safe drinking water, and these downstream factors fall into 4 different categories: the physical environment, economic and work environment, the social environment, and the service environment. The physical environment, again, includes access to transportation to get people to and from clinic, housing, poor housing that are not being repaired, environmental things in terms of mold and mildew, et cetera, exposure to toxins, economic and work environments in terms of higher unemployment, income, or even diminished sort of retail business or occupational hazards. Social environment, which includes, I want to also say includes media and marketing in terms of how things are either marketed or not within communities of color. Also, within the social environment includes violence, racism, gender, and immigration. And finally, service environment, which includes healthcare, education, and social services. This next slide talks about the percent of individuals living in crowded housing by race and ethnicity. I mentioned over and over again in terms of social determinants of health, in terms of housing. And here you can see that those that are living in crowded housing, and I want to say just during the pandemic, we learned that this was one of the ways in which the COVID virus went through many homes, and the fact that a lot of people were living together in small spaces. And we saw a lot of this within the Hispanic and Latino community here in Brooklyn, in particular in terms of our Afro-Caribbean population. The prevalence of food insecurity among Medicare beneficiaries 65 and plus by race and ethnicity, overwhelmingly disparities with compared to white counterparts in terms of food insecurity among Hispanic and Blacks. The older Blacks and Hispanics are more likely than older whites to report problems paying for health care. This should be no surprise. in terms of blacks reporting 16%, saying that they or a family member had problems paying for health care, which includes paying for medication. And the second column, in terms of those reporting having an annual income, household income less than $40,000, again, we see that blacks and Hispanics and Asian had a higher burden of low income compared to their white counterparts.